It's 7 o'clock. Thanks to everyone for joining here promptly, and I have the good fortune to introduce our speakers today. We're fortunate to have a multidisciplinary talk today on a complex topic that many of us see at Phoenix Children's. So, he's being loud here, sorry. Bianca Roman is a certified pediatric nurse practitioner here at Phoenix Children's in the PMR, Physical Medicine and Rehabilitation Division, where she evaluates children with complex rehabilitation needs and works closely with the multidisciplinary teams. Bianca does much in this capacity, but she has developed a special clinical interest in supporting patients with functional neurological disorder, FND. Bianca also serves as chair of the Advanced Practice Provider Service and Community Engagement Committee, where she leads initiatives that connect healthcare professionals with meaningful volunteer opportunities to support patients, families, and local communities. So I like that, and I wanted to highlight that as well. And then Zorash Montano is a licensed clinical psychologist who's been part of the consultation liaison CL team at Phoenix Children's since 2020. And this group includes psychologists and psychiatrists who work with the medical teams to address the psychosocial needs of hospitalized children and their families. She has become passionate about working with patients with functional neurological disorder, FND, through her work on this consultation liaison team. She has collaborated with stakeholders across the hospital to create an FND clinical guideline to guide and standardize the care we provide to patients with FND. And she's a member of the Functional Neurological Symptom Disorder Special Interest Group through the Society of Pediatric Psychology. So they're here to share their expertise with us on the topic of inpatient rehabilitation, multidisciplinary approach to functional neurological disorder. Welcome, Bianca and Zorash. Thank you.
Yeah, thank you. Um, I just want to say a quick thank you. Yeah, I'm really passionate about caring for this population, so thanks for letting us talk to you today about it.
Yeah, we're excited to share what we've been doing in rehab. Okay. Thanks for the introduction, Dr. Lewis. Okay, just a quick review of the objectives today. We want you to be able to identify what has changed about diagnosing FND. I know if you've heard any of talks that I've given, we always review that, but I just want to make sure, as much as a hospital, we can be on the same page and using the same language. I think it's going to be best for our patients. We really want for you to take away be able to identify an appropriate referral for physical medicine and rehab. And this wouldn't be just for inpatient, just like when do we get PM&R involved? And then be able to describe an appropriate candidate with FND for inpatient rehabilitation program. So again, so we're all starting from the same page, I want to review the criteria of diagnosing functional neurological disorder. As you know, for the DSM, it's functional neurological symptom disorder. And then the revised version, it's FNSD and in parentheses conversion, which used to be in the previous version, conversion disorder was the main one. So the diagnostic criteria include one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. Not better explained by another medical or mental disorder, and the symptom or deficit cause clinically significant distress or impairment. I think what interests me so much about FND is probably that it requires such a multidisciplinary approach, right? I can't read an MRI or an EEG, so we really rely on our neurology colleagues to let us know if those clinical findings are incompatible between symptoms and recognized neurological or medical conditions and what the findings are. So it really requires all of us working together. So for FND, there's different symptom types. There's attacks or seizures, abnormal movements such as tremor, dystonia, myoclonus, gait disorder, swallowing and speech disturbances, sensory loss, and mixed symptoms. Some important considerations are that psychological factors such as stressful events or trauma are no longer part of the diagnostic criteria. And actually, you can add a specifier to your diagnosis with a stressor or without a stressor. However, trauma and psychiatric symptoms are risk or predisposing factors. But we don't have to have it identified or the patient have one to have this diagnosis. Additional important considerations are that FND is no longer considered a diagnosis of exclusion. It should not be made simply because the tests are normal. It is not simply made because the symptoms are bizarre or rare, and really should be based on overall clinical picture and include positive findings. And positive findings can include, for example, for functional limb weakness or paralysis, the Hoover sign, hip abductor sign, discrepancy with on-the-bed performance compared with another task. For functional tremors, it can be the tremor entrainment test, variability in frequency, direction of the tremor. And I think it's really from anecdotally when families are given these kind of like the inclusion criteria, those positive findings, there's a lot more buy-in, and you'll see through this talk, we'll talk about how important buy-in is, and we've realized that for rehab.
Receiving a clear diagnosis of FND from an experienced pediatric neurologist is incredibly important. In order for a patient to receive the correct treatment for their condition, they obviously have to know what they have and agree with the diagnosis. And we found that this buy-in from patients and families is especially important with FND. And it, like Zorash, Dr. Montano just said, it's really important to point out the positive findings on diagnosis rather than just tell them that their tests were negative and therefore that's why we think they have it. So, when you're diagnosing it, you can say your tests were normal, and then also we found X, Y, and Z on your physical exam, and that's why we feel confident that it's the correct diagnosis. Without a clear diagnosis, the patient won't receive the specific treatment that has been shown to help patients with FND. So for example, physical therapy techniques for other neurologic conditions such as brain injury focus on building strength and endurance, among other things, whereas with FND, they're going to focus on functional movement and motor retraining, and they utilize a lot of distraction techniques. And then the other really important reason why we want the diagnosis as soon as possible is because early diagnosis and a short duration of symptoms are positively correlated with outcome, whereas delayed diagnosis is negatively correlated with outcome.
Along with getting buy-in and presenting all the factors that are informing the diagnosis, really the way we talk about the diagnosis and the symptoms helps the family and the patient feel validated, heard, and feel safer and have more trust in their diagnosis. So for example, if we say your MRI was normal, there's nothing wrong with you, you're fine, or it's just stress, or you just need to work with a psychologist. The patient might think, well, I don't feel fine. They think I'm making this up, or they think it's all in my head. I think we hear that a lot, right? Like they think it's just in my head, even if you don't use those words. Or, well, they didn't do the right test. They're missing something. What if they're not checking for the right things because they don't believe me? And having these thoughts and feelings just leads to worsening of symptoms. And typically they won't follow our recommendations, right? Not only will they won't get the right treatment, but they will probably won't follow what we're recommending for FND treatment. So I know historically we've used things like unexplained symptoms, pseudo, psychogenic, behavioral, stress-related conversion, but we really want to move away from these symptoms. Why? They're outdated terms. It really talks about all of it being psychological, which is not totally accurate. It suggests that the symptoms are just due to anxiety. It suggests they might be fake. It suggests that they're under their control, such as the behavioral term, or maybe that we haven't done enough tests and we're just missing something. Okay. So as psychologists, when we're doing our evaluation, we're really looking at the biological, psychological, and social factors. Just going along with it's not just stress, it's not just anxiety. The psychological factors can be predisposing, can be precipitating and perpetuating factors. As we know, risk factors can also be biological, right? It can be their own illness exposure. Do they have a history of a neurological illness? Sorry. Does their family, a family member have a neurological diagnosis? Is there increased self-monitoring about their symptoms and the way they're interpreting what happens in their body? This can be more the social piece, is there parent reinforcement and concern over physical symptoms more so than emotional? And when we put this together for our families, not only for us does it help us understand what's going on with the patient, sometimes it helps us identify intervention targets, but for families, again, they really feel seen and heard. as we know and we've seen, a precipitating factor can be biological too, right? A viral illness, a surgery, a procedure. It doesn't have to be this traumatic event or this really psychologically stressing event. It can really be biological as well. So again, I think really moving from it's just stress and really understanding this complex interplay of factors really helps us understand the patient better, and they feel more understood as well. So when we have all of these factors, different factors at play, it really requires a multidisciplinary approach, and that's what we're offering in our inpatient rehab unit.
A study by Macias Garcia et al. Compared treatment for FND with cognitive behavioral plus physical therapy versus just psychological support intervention alone. And at months 3 and 5 in the study, 42% and 47% of patients, respectively, in the multidisciplinary group reported improved health using an EQ-5D scale, compared with 26 and 16% of patients in the control group. And the EQ-5D is a standard questionnaire that measures health-related quality of life. There are also prospective and retrospective studies that have found that up to 63 to 95% of children can attain a full remission after inpatient rehab treatment. So the multidisciplinary approach at Phoenix Children's Hospital that we're using with FND involves coordinated family-centered care between a lot of different teams. It's the hospitalist, neurology, psychology, PM&R, PT, OT, speech, sometimes social work, and case management. So just a little bit about the inpatient rehab at Phoenix Children's Hospital. We have 3 physical therapists, 2 OTs, 1 speech, and those are all dedicated to rehab, along with dedicated rehab nurses, a child life specialist, a dedicated social worker and case manager, neuropsychologist, and school teachers. We now have 6 providers in PM&R. We have 2 physicians, Ray Stanford and Cesar Astudillo, and 4 nurse practitioners. Myself and Nikki Vernelli are working inpatient, and Megan Art and Kristen McElliott working on the outpatient side. We have 12 beds on our unit, and we are CARF accredited, and CARF is the Commission on Accreditation of Rehab Facilities. We're the only pediatric rehab in Arizona. St. Joe's will take patients 16 years and up, but they are limited in which patients they can take. For example, they don't take treatment patients, and we do. And then we also get referrals from Nevada and New Mexico, as their pediatric rehabs are limited.
I guess, sorry, I should add that the 3 consultation liaison psychologists see patients in rehab.
So when should you get PM&R involved? So, for example, a patient will come in with some kind of neurological symptoms, and the medical team will consult neurology. They might order some testing and then ultimately diagnose the patient with FND. As Dr. Montano mentioned, there are different subtypes of FND, and PM&R does not need to be consulted for every type. PM&R can be most helpful when a patient has symptoms of FND that include weakness, impaired gait, numbness, impaired speech and cognition, or impaired swallow. Or potentially if they have a mixed presentation, so they could have impaired gait and weakness plus syncope, or impaired gait and weakness plus non-epileptic seizures. However, if their presentation is strictly syncope or non-epileptic seizures, PM&R does not need to be consulted unless the team suspects that the patient may have secondary changes. And secondary changes include muscle tightness and contractures, deconditioning, fatigue, and sensitization of pain. If those factors are present, or if the team isn't sure if those factors are present, PM&R can be consulted, because secondary changes can lead to a situation where a patient is now adapting to their symptoms, which can lead to disability. So for example, I had a pediatrician ask me to evaluate a girl for inpatient rehab with the FND with a syncope subtype. And I initially told the pediatrician that we don't take patients with syncope FND to rehab, but then I did agree to evaluate her in clinic so that I could see if she had secondary impairments, such as deconditioning, since she hadn't walked in months. And when I evaluated her, her arms and legs were actually really strong. So I did not end up recommending rehab, but I was able to still provide her and her family with some education and help set up outpatient therapies. Okay, so going back to the situation where the patient is in the hospital and they've just been diagnosed with FND by neurology, and it's a subtype that PM&R can help with. So that's when PM&R should be consulted. So we will receive the consult. We'll make sure that PT, OT, and psychology have also been consulted. If they haven't, I'll request that those consults be placed and I'll wait to meet the patient until after they've done their evaluations. And this is because I need to know from PT and OT whether the patient is safe to discharge or not before I can make a recommendation for the treatment plan. So if the patient is safe to discharge home from a PT-OT perspective, our first line treatment is going to be recommending outpatient therapy first, so PT, OT, and mental health. The medical team or PM&R can order stat, outpatient, PT, OT, and speech if needed. But PM&R can help to make sure that they get these evaluations scheduled before the patient is discharged from the hospital. We really don't want there to be a gap between discharge from the hospital and starting outpatient therapy. And the same with mental health. Psychology and social work can assist with ensuring that there's mental health set up prior to discharge. I like to see these patients in clinic about 1 to 2 months after discharge so that I can make sure that they actually started all of their therapy and I can see how they're doing. So if the patient is in acute care and they're not safe to discharge home, or if they have limited or no access to outpatient therapy, so they might live in a rural part of Arizona, then we can consider coming to inpatient rehab first. Or if a patient was deemed safe to discharge home and they've been doing outpatient PT, OT, and mental health for several months, but they're not making progress, then we can consider inpatient rehab. So there's a couple different pathways of how they could come to rehab, either from home or from acute care. If we do recommend inpatient rehab, the typical length of stay is about 2 to 3 weeks, but can be longer for more severe cases. And the really key point to take away from all of this is that we really need clear, direct communication between all of the specialists in order to present a unified approach and plan to the patient and the family. We can do the family and patient disservice if one team goes in and says, don't worry, you're going to come to inpatient rehab and you're going to get better. And then I go in and tell the family that I'm recommending outpatient therapy. So it's really best when we all know what the plan is and go in together and present that unified plan. We also have a couple of reasons for recommending outpatient therapy first. One, we'd like them to return to their normal routine as soon as possible. And we really encourage kids to stay in-person school instead of switching to online school or homebound. And another is that we may see an improvement in their symptoms in a really controlled environment like the hospital, but then they might go home and we really want to see if their symptoms can be improved in the home environment. So we like to save inpatient rehab as more of a last resort if they're not getting better in the outpatient setting. We're also trying to enforce the idea that they're well and their bodies are strong and healthy. So a prolonged admission in the hospital can subconsciously enforce the opposite idea that they're sick. So when possible, we like to try outpatient first. So knowing which patients are eligible for rehab can be somewhat complex, and PT, OT, and PM&R all work together to decide if a patient is eligible for rehab. But basically, they need to show consistent functional deficit in mobility skills, self-care skills, cognitive skills, or feeding skills that require at least 2 separate intensive therapy disciplines. So they can't only have physical therapy goals. They need to have at least, PT and OT speech. They could have all 3, PT, OT, speech. And they need to require that intensive 3 hours per day, 6 days a week intensity. They also have to be able to participate and tolerate that intense level of therapy. Okay, so the patient has been diagnosed by neurology with FND, and then PT, OT, psychology have done their evaluations. So before I'm going into the room to meet the family, we're discussing the plan. And then if we happen to decide we're going to offer inpatient rehab as an option for first line, then the next step is for PM&R to go in. and we'll meet the family and patient, we'll get the history, do a physical exam, and then I will administer this questionnaire to the patient and their parents, and they do fill this out separately. So the first question on the questionnaire is, how well do you think you understand the diagnosis of FND? And they rate between a 0 to 10. So I'll accept a rating of 5 or above, because really if they're scoring less than a 5, it means they don't understand what FND is. And so answering the next few questions is going to be quite difficult. So if they happen to score lower than a 5, it just means we need to first kind of pause and talk to them about what FND is again. And this can be done by me, the psychology team, or neurology. But we need to get their understanding to be at least a 5 on what FND is. I don't expect it to be perfect right away because they've just been given this diagnosis. So it does take time for them to understand it. And so the next question is, which statement most accurately represents your acceptance of the diagnosis? So they could say, I don't think it's correct. I'm willing to think about it, but I'm not sure. Or I think the diagnosis is correct. And the only way to proceed to inpatient rehab is if they select C, that they agree with it. And that's because having that buy-in is so important for their recovery. So if they select A or B, it just means, again, we need to have more conversations. Maybe they want to talk to neurology again. They might ask for more testing. And we just need to, again, explain, why we think they have it. And those positive findings can really help to convince a patient that it's the correct diagnosis. So,
Sorry, as
Yeah.
you'll see, we're going to go over the rehab guidelines of what we expect these patients to do once they get to rehab. And it's not easy. And what we're asking them to do is really difficult too. So if they don't agree with the diagnosis, the parent and the child, it'll be really hard for them to follow through what we're asking them to do. So that's why we really believe in this and how important it is as a first step before they start rehab.
So once they do agree that it's the correct diagnosis, then we can move on to the next question. To what extent do you expect to recover from the diagnosis? And I'll accept a score of 6 or above on this. But if they're scoring lower than a 6, that's just kind of means we need to explore with, maybe me or psychology, exploring why they have a negative outlook on their recovery. We want them to know that FND is treatable and people can get better. And the inconsistency of their symptoms means that it's reversible. So, we just might need to explore why they don't think that they'll recover. But we need them to believe that they can recover in order for it to work. Because if they don't think they're going to get better, then they're not going to get better, and inpatient rehab won't make a difference. So we do have to have them believe that they can recover. So once they're scoring kind of 6 or above, then the last question is, what are important goals they'd like to achieve at the end of rehab? And I like this question because I can sometimes catch some goals that are not achievable in rehab. So for example, if they have chronic pain and FND and they write that they want their chronic pain to be drastically reduced or gone by the time they leave rehab, I just need to let them know, we're coming to rehab to treat the FND. We want your mobility to improve. We want you to be more independent with your activities of daily living. And if all of the strategies we use in rehab help to make your pain better, that would be great. But that's not why we're coming to rehab. So it's not going to hold up discharge if they're still having pain. And typically, if they have chronic pain, that's going to take some time for that to improve. It's not going to happen really quickly in the an acute rehab stay typically. And just a little bit about this questionnaire. Dr. Montano and Dr. Ng, who is a physiatrist who left our team last year, developed this questionnaire for use at Phoenix Children's to help us select appropriate candidates for rehab. So once the patient and family have scored appropriately on the questionnaire, then I'm able to discuss inpatient rehab as a treatment option. But in order to make the most of their rehab stay, we ask that the patient and family sign our FND rehab guidelines. We use this set of guidelines to ensure that we have buy-in from the patient and family regarding the diagnosis and treatment plan, reduce factors that can contribute to their FND, ensure the focus is on functioning, and ensure that they're motivated. So some of the guidelines that help ensure buy-in are that, again, they agree with the diagnosis, that we won't do any further medical workup in rehab unless they're having symptoms that we believe are not attributed to their FND. And then, of course, we would need to work that up. And they must participate in everything: PT, OT, speech, psychology, school. We have guidelines to help reduce factors that can contribute to their FND symptoms. So parents are allowed to stay at the bedside, but they can't join the therapy sessions until we're getting to the end of the rehab stay and we need to do family training and education. We don't want the patient receiving gifts cards or any other sort of special treatment because they're in the hospital, because we don't want to subconsciously reinforce the idea that they get attention or special treatment when their FND symptoms are flaring. So alternatively, we want to encourage parents to give praise and attention when their child is functioning well and their mobility has improved, so that we're positively reinforcing health and wellness. We don't allow patients to have their phones or access to social media. Only the legal guardians can stay at bedside, so no other family members, siblings, or friends can visit. The patient can call their immediate family in the evenings or on Sunday. And again, all of these rules are just to break up any routine that could have led to the development of their FND symptoms. And then we have a few guidelines that ensure their focus is on functioning, and we want them to just kind of be in as much of their normal routine as possible while still being in the hospital. So we want them to wear regular clothes, no pajamas or hospital gowns. We want them to be ready, prior to the first therapy session. We have them attend the One Darn Cool School, or a school teacher comes to their room and works with them, and they have to complete all school assignments. So if they're following all of our rules and they're doing all of the homework assigned to them by the therapist, then they can earn additional privileges. And we do this to help kind of motivate them. So they could earn a privilege to go to the zone, or maybe a sibling could visit for a set time on a Sunday. I'll talk about equipment a little bit later. We do reserve the right to discharge sooner than agreed upon if they refuse to comply with the guidelines. Inpatient rehab goals are really individualized, and the length of stay is different for each patient, but we do try to make it clear that they may not be completely free of their symptoms by the end of the rehab stay. We're hoping for an improvement in symptoms, increase their education on FND, and hopefully set them up for success in the outpatient setting. So again, just to briefly recap the admission criteria for FND, we need to have a confirmed FND diagnosis and the patient and family accepts that that's correct. The psychology eval is completed when they're coming from acute care. If they're coming from home, that will get done when they're inpatient. The PT and OT evaluations are done, and they've determined that they have inpatient level goals. And this happens whether they're coming from acute care or coming from home. These evals get done prior to coming into the hospital to ensure that they have the inpatient level goals. And then no pending or upcoming medical workup. And we want a patient that's really motivated and engaged in the treatment plan. And then they've filled out the questionnaire, and then both patient and parents have signed the FND guidelines. So I wanted to run through a case study to kind of demonstrate how some of these consults go. So Susie is a 12-year-old girl with a past medical history of anxiety who presented to the emergency department with headache and neck pain. And she was admitted for over a week. Prior to the admission, she had some URI symptoms, neck swelling and neck pain. And then over the course of the admission, she had a whole constellation of symptoms, including nausea, photophobia, blurry vision, impaired balance, dizziness, fatigue. She was speaking more slowly. Her voice was hoarse. So the medical team did a fast MRI, and it showed a Chiari-1 malformation with no serings at that time. So she received some treatment for her headaches, some antibiotics for sinusitis, and discharged with instructions to follow with neurology and neurosurgery. However, she was readmitted shortly thereafter with headaches again and neck pain. And then she had diplopia that waxed and waned. Neurology was consulted again. They recommended the headache protocol, and she was trialed on propranolol for anxiety. They decided to do a full brain and spine MRI, and this showed the Chiari-1 along with a syrinx at C6. So this time she was also discharged with recommendations to follow up with PT and OT, along with neurology and neurosurgery. However, mom said that she was never called to schedule the PT and OT, and I do hear that a lot from parents. But she did get in to see neurology and neurosurgery, and then she started mental health therapy in March. However, in March and April, mom reported that her legs started to give out, her balance was impaired, and she would fatigue easily. She started going to the comprehensive pain clinic in May, and her symptoms actually began improving in May, but then reoccurred. So they did another brain and spine MRI in June, which showed an increase in size of the syrinx. So she saw neurosurgery in early July. They recommended doing a decompression of the Chiari-1. So she was admitted in late July for that surgery. But after surgery, her symptoms actually worsened, and then she was unable to walk independently or perform ADLs without assistance. So PT and OT were consulted, and then PM&R was consulted. So when I got the consult, I thought it was a little strange. It was a patient that had this surgery and then had worse symptoms. So I called neurosurgery before I met the patient and said, did the surgery go okay? What were you expecting to see? And they said the surgery went totally fine, but, we definitely did not expect to see these symptoms after surgery. So, they were thinking, maybe there's something else going on unrelated to the Chiari-1. So I went in, met the patient and mom, got the whole history, did a physical exam. And at the time of my consult, her symptoms also included knee buckling with gait, blurry vision, double vision when looking to the right, impaired balance, stabbing pain to the top and back of her head, dizziness, low appetite, and mild urinary retention. And mom told me that she had had somewhere between 3 and 5 falls in the home since January. So some red flags that I was kind of picking up on in this consult were that her symptoms had waxed and waned since January. She didn't have the outcome expected by neurosurgery after the decompression. When she was walking, her knees would buckle, but she could catch herself and stand back up. And then she had giveaway weakness on a manual muscle test. So I suspected that she might have FND. So what I did was I told mom that I thought her symptoms were not due to the Chiari-1, and I wanted to ask the medical team to re-involve neurology, and that I would follow up with her after neurology saw her to talk about what we wanted to do from a therapy perspective. So the medical team consulted neurology, and they did their own exam, and they diagnosed her with FND. And then I had also asked the medical team to consult psychology as well. So psychology met her, and then PT, OT, psychology, and myself all kind of talked about what we wanted to do before I went in to talk to mom again. So we discussed how she was on the border of being safe to discharge home, but some things that we were kind of thinking about were that she had a history of falls in the home. Her bedroom was on the second floor, and we hadn't practiced stairs yet. Mom was really scared about her falling on the stairs. And I was also thinking about the length of time that it took for her to be diagnosed. It had been about 7 months. And then she could walk in the hallway and the room with maybe contact guard with a physical therapist, but when parents were there, she needed more assistance. So what that kind of clued me into was that parents may be inadvertently reinforcing the FND symptoms rather than promoting wellness. And so we needed to do some education with parents. So we decided to offer inpatient rehab as a first-line treatment for Susie. And Susie and her parents agreed with the diagnosis. They expected to recover, and they agreed to our guidelines. So we admitted her to rehab, and she only needed to stay for 1 week. And then by discharge from rehab, she was completely independent with transfers. She could walk more than 800 feet independently. She could ascend and descend 12 stairs with standby assistance. Her headaches were still present, but drastically decreased in severity. So that was just kind of a bonus kind of thing that she got out of rehab. And then we made sure that she had PT and OT scheduled before discharge this time and outpatient mental health established, and then made sure she had follow-ups to PM&R, neurology, neurosurgery, and the complex pain clinic. And then I saw her a few months after rehab, and she had a normal gait. She was in school full-time getting A's and B's in honors classes, independent with mobility and ADLs. Her migraines had resolved. She still had some back and neck pain, but it was decreased in severity, so she had been discharged from the pain clinic. She still had a little bit of difficulty sleeping at night, and sometimes her knees would buckle when she would overdo it, which I thought was an insightful comment from her, because we do see in FND, some of our FND patients have perfectionist tendencies. So when they are having a good day, they can really push themselves and overdo it. And then that kind of sets them back the next day. So I talked to her about the importance of pacing herself. I love this diagram because I think it does a great job to explain the pathophysiology behind FND in a relatively simple way. And if you know the pathophysiology, you'll know why the FND strategies we use can help. So at the top, a person could have some risk factors for FND, and then something in their life can trigger initial symptoms. Then the body has a flight or fight response to the symptoms, and we see that the nervous system becomes dysregulated. The brain starts to then hyperfocus on movement, and that hyperfocus of attention on the movement disrupts normal movement control. So that's why using distraction in PT and OT can help, because it takes their focus off movement and allows movements to become more automatic. The other thing that happens in FND is that the brain has a prediction error. The brain predicts that the body will move abnormally, and then it plays out that abnormal motor program. So movement retraining techniques utilized in PT and OT helps reprogram faulty motor patterns to restore normal movement. So again, just physical therapy focuses on retraining and redirecting attention off movement to show that normal movement can occur. And we use a lot of different strategies to do that. But basically, we're looking for a way to change the movement pattern. So we could add an external focus, add a dual task, add or change visual input. They could do tasks with eyes open or eyes closed. We could use mirrors or videos for visual feedback. We could add sensory input like compression or weighting, change the position a task is done. They could walk on a treadmill. We could increase or decrease the speed. And we try to elicit automatic movement by using a metronome. Or we could use a novel task. So using a novel task can help because their brain is going to play an abnormal motor program for walking or other tasks that they've done before. But for a task that they've never done, their brain won't know how to predict it. So sometimes we can see if the brain will play out a normal motor program with a novel task. So for example, we could ask them to walk down the hallway like a penguin, or hold a pillow, and the PT will throw a ball and ask that they catch the ball with the pillow while they're walking. And then they could even combine that with a dual task like counting by threes or naming animals that start with the letter M or something, so that we're distracting and using a novel task. Just a little bit about equipment and our thought process on equipment. So we know that equipment can lead to overdependence and possibly result in secondary impairments such as deconditioning. However, we want the patient to be as functional as possible. So if they come to us in a wheelchair and by the end of rehab, they're able to walk safely, but only with the help of a walker, we could recommend that they go home with a walker because it will make them a lot more functional than if they're in the wheelchair all the time. But the goal for us is always to try to wean off of all equipment eventually.
And for psychology, when we see patients in rehab for FND, we see them about 5 to 7 days a week, depending on their needs. We use a cognitive behavioral approach, and from a CBT perspective, we understand that our thoughts, feelings, and behaviors are all connected, including how our body feels or those physical symptoms. Really, at the beginning, we focus on thoughts, feelings, and behaviors related to FND symptoms. If a patient has comorbid trauma, depression, anxiety, we are not often treating that directly, but more we're working on the coping with FND. We address any cognitive distortions or thoughts about their symptoms. Also thoughts that they might have about or feelings in physical therapy and OT of, I can't do this, I'm gonna fall. All of that can contribute to that autonomic nervous system activation, and we really want to work on that. We also work on building insights, so making their own connections of like, how does my body feel when I have these feelings? What are the thoughts associated with that? And them starting to understand those connections within themselves. And then we teach strategies to regulate their stress responses, to regulate their nervous system. We provide psychoeducation to parents and to the patient as well. Actually, a lot of the first sessions is really focusing on that and ensuring that they really understand FND, that we're answering any of the questions they have. We also discuss with parents how to support the patient during the admission and after the admission. And then we work on reinforcing functioning from ourselves and how the parents are reinforcing that as well.
So a typical day in rehab will look like 3 hours of therapy. So if they have any speech issues, it'll be an hour of PT, hour of OT, hour of speech. But if they only have PT, OT needs, then it's kind of a split 3 hours between PT and OT. They have 30 to 60 minutes of psychology, an hour of school, and then they have homework assigned by everyone. So PT, OT, speech if they have it, psychology, and psychology could assign them, journaling, meditation, or other coping strategies. They have homework assigned by school. And then if they've done all of their homework, they're following all of their rules, then like I mentioned earlier, they can have privileges such as zone time. We also have a weekly team conference where we get the whole team together. So it's PM&R, psychology, PT, OT, speech if needed, case management, social worker, our school teacher, and the family. And we discuss all together their progress, goals for discharge, timing of discharge, and planning for discharge. And planning for discharge includes setting up outpatient appointments ahead of time, as well as ordering any equipment needed for the home. So how are we doing at Phoenix Children's? WeFM is a tool that helps us measure how well children independently mobilize and perform basic activities of daily living. And we give them a WeFM score at the start of rehab and then at the end of rehab. So the average WeFM gain for our FND patients from 2021 to 2025 was 32, compared to an average WeFM gain of 25.5 for our acquired brain injury patients. So we're doing really well. However, we have identified that there are still some barriers to treatment and helping these patients recover. There's really not enough PTs, OTs, and mental health therapists that are trained in specific FND techniques and approaches in the outpatient setting, especially. There's oftentimes a delay between the start of symptoms and the time of diagnosis. And sometimes symptoms will improve, but then recur, and the patient and family is really discouraged and at a loss for what to do. There was a systematic review that looked at studies with 8 or more patients with FND that reported follow-up data longer than 6 months, with a mean average follow-up duration of 7 years. And the review showed that 39% of patients with FND were the same or worse at follow-up. And then another issue we see is that a patient could have new symptoms and they're unsure if it's FND or something else. And this really ties into the fact that there's just a lack of follow-up with a medical provider really familiar with FND to help guide these patients in the outpatient setting. There is evidence that shows that outpatient multidisciplinary programs for FND can reduce relapse rates and reduce visits to the emergency department for FND-related symptoms. And the systematic review also noted that patients that are more satisfied with their care have more positive outcomes. So if anyone is interested in working with me to create a robust outpatient multidisciplinary program, I'm very interested. The no-show rate for FND patients in my clinic is pretty high, but I think some of that has to do with just the burden of having a lot of appointments. So a multidisciplinary clinic could decrease the number of visits with providers while improving their satisfaction with care. So what are we kind of doing about these issues? A lot of education. So Dr. Schaefer, one of our other psychologists, and Dr. Montano gave a grand rounds presentation to the hospital on FND to increase their education. Dr. Montano gave a talk on FND to the acute care and outpatient PT, OT, and speech therapists to increase their education. We had Kennedy Krieger's staff from their FND program talk to us twice now, and the first one was on how their program operates, and then the second one was specific PT, OT speech strategies for FND patients. And Dr. Montano and I have formed an FND work group, which includes staff from PT, OT, speech, PM&R, neuropsych, psychology, and school teachers.
And a hospitalist now.
Oh, awesome. And then we meet every couple months to discuss, you know, what can we improve upon? How's our program going? Work through different issues that can come up. And one of our rehab occupational therapists did a training with Reactive, which is a treatment program for FND. So we're going to hear about how that went at our next work group meeting. And then Dr. Montano gave an in-service to the hospital school teachers last year on how to help patients with FND return to school safely. I wanted to end with a few resources that you all could give to your patients that you see with FND. So the first is a workbook called Reset and Rewire, the FND workbook for kids and teens. And it's only $16.99 on Amazon. And I'm trying to get some ordered so that I can give out in my clinic. So that's something that maybe neurology could think about too. But it's a really great workbook with helpful diagrams and metaphors that help explain what FND is and how they got it. It has a lot of great coping strategies, ways to, you know, reset their nervous system, and then information that they can give to their school and family. Next is the Neurosymptoms FND Guide app, which has resources for patients with FND. And another great app is the My FND app, and this has resources as well as a symptom tracker so that patients can track when they have a good day, what circumstances led them to having fewer symptoms, and then when they're having a kind of a worse day where symptoms are flaring up, what circumstances might have led to that, so that they can start drawing conclusions as to what's reinforcing their symptoms and then what's helping them get better. And then, of course, always please feel free to reach out to PM&R if you have any questions about a patient with FND, as we're happy to help. Thank you. Any questions?
Exceptional.
Hi, this is Corbin Williams. Thank you so much for that. It's very interesting and helpful in many ways. I had two questions from a 360 perspective. I think you've touched on this a little bit, but anything explicitly that you feel that we could, from a neurology perspective, do a little bit better as far as education for families? I did notice you say that when the diagnosis is provided by a senior child neurologist, but we also have a training program, and I don't want our junior colleagues to feel like they can't make this diagnosis and have this discussion. And then the second question is, I'm always curious about the failures. So the people who are doing everything that you asked and they still aren't getting better, any thoughts as to why that's the case?
I think to the first question, you know, as long as the person going in has a good understanding of FND and can it help explain to the family, you know, tests are negative and but also the positive findings. And then, you know, a lot of people use the computer analogy where you know, your hardware is good, but it's a software issue, but really kind of explaining like what that means. Because I'll have patients where I'm like, you know, do you know what FND is? I go in and they're like, well, they said it was a software problem, but I don't really know what that means, you know, but it is a great analogy, but it's like, yeah, like if we took the computer apart, we can't see what's, you know, we're not going to find what to fix, but it's a bug in your software that, you know, so there's still something wrong. So just kind of letting them know, even though the tests are negative, we know there's still something going on. There's something wrong there. So
And I think they do take more time, right, providing that education, but we just seen it's worth it. It goes a long way and it really pays off to spend that extra time in the beginning because everything else follows, you know, following treatment guideline recommendations and everything. So we really think it's worth spending that initial time, making sure there's good buy-in and a good understanding of what the diagnosis is. And that it's real. The symptoms are real, right? The bottom line.
And I think I lost my train of thought.
When things don't go well. Sometimes what I've seen is, because I know I've seen patients who might have like, well, I'm going to therapy, I'm doing everything, but maybe there's not really good buy-in on the diagnosis, or there's other reinforcing factors that we haven't targeted, and it might be revisiting that biopsychosocial model and seeing what's missing and what we haven't addressed. That might be one of the things.
And I think some of it is finding good people in the community that like PTs, OTs that really know the strategies to help them. Because if they're seeing a physical therapist, but they're using strategies that are not geared towards FND, it's not going to help. So I do have some some people that I can refer to if you want to reach out to me. I'm happy to email you some. I know a couple of psychiatrists that are really familiar with treating FND, some outpatient PT, OT, and then an outpatient psychologist too. Um, and then one thing I want to mention is for those kind of difficult to patients that aren't getting better, it might be good to refer them to psychiatry to see if they might benefit from an SSRI if they have some depression or anxiety symptoms on board. There is a lot of research that's showing that SSRIs can help a lot of these patients, and it can sometimes be difficult to tell that they have depression or anxiety because they're not really in tune with their own emotions. So it's hard for them to express, I have anxiety or I have depression. So it can take an experienced person to kind of see if they have those symptoms on board and then benefit from an SSRI. What else?
Hey guys, Jay Hautman here. So that was terrific. And there's more overlap, I think, with what we see in neurosurgery than actually meets the eye. And I wanted to explore this with you guys in the last couple minutes that we have together. Okay, so what you just spent the last 45 minutes describing, in my opinion, is the worst of the worst, the most extreme spectrum of functional neurological disorder, where these are kids who have really no organic basis or minimal organic basis to their symptoms, require rehab, require that whole approach that you beautifully detailed. But there's this huge swath of kids that we see in neurosurgery who are in the in between, who have clearly real symptoms, like you just said, which I thought was like, I say this in clinic all the time. Your pain is real, your headaches are real. It may not be because of X, Y, Z, which is the reason why you're seeing me, but that doesn't mean I'm not saying that your headaches are in your head or I think they're real, right? And so the hardest thing that me and Doctors Bristol and Ronacher, Chiarelli, Schaffer, and the hardest thing we have to do in clinic is we have to see all these kids who have these benign MRI findings who have a symptom. And it's never really clear whether the symptom began before they got the MRI or after. Sometimes you don't know. Sometimes it's before, sometimes it's after. Sometimes it got worse once they knew the diagnosis. But Chiari's and tether cords, arachnoid cysts, pineal cysts, all these things you guys send to us all the time in clinic that you find on an MRI with a symptom, because headache is the most common reason these kids get MRIs. And then our job is to sort of shuffle through what we think is an organic symptom and a non-organic symptom, which is exactly what you're talking about. We spent the last 45 minutes talking about. And I really sort of wonder out loud, when you think about the meta of it all, like these are impossible Mobius loop type problems because so I see a kid with headache and arachnoid cyst and I say, well, it's not the arachnoid cyst. And then maybe they go to neurology and maybe the headaches don't really respond to any of the conventional therapies. So now this is a kid with a symptom that we don't think is organic, but isn't really labeled as FND because they're not so severe. They're not going to school. They're being admitted to the hot, like the things that you guys are describing are kids who are no longer functioning in a way that's like appropriate, right? But there's thousands of kids in this in between who are rewired to have these symptoms that we don't have an organic explanation for. And so the question I ask of you with that 2-minute preamble, I'm so sorry, but that 2-minute preamble, it's like, what do we do about those kids? Because I think those kids are actually the most kids that we see as an outpatient clinic who could probably benefit from a comprehensive 360-degree evaluation, the way Corwin just nicely described it. I don't know what to do. I mean, I think these are the majority of the kids that we see in neurosurgery clinic that we don't operate on.
I have a thought. I do think everything can coexist, right? I think sometimes those chronic pains are a risk factor for developing FND when it hasn't been addressed. This happens in patients sometimes when a patient might be discharging, and I'll ask the team, even if we're not diagnosing with FND, is this patient safe to do PT? Is this patient safe to go to school in person? Yes. So are they safe from your perspective to engage in these more functioning focused goals? And so can we still have that intervention, even if we're not calling it FND or I guess I don't know if that addresses the family's anxiety of like, is it that cyst or is it, the Chiari? But I do think finding a way to still help them engage in this type of treatment in a safe manner can be helpful.
See, but I agree, but we could overwhelm you quickly. I mean, like, so examples, like how many of my partners have done a Chiari malformation decompression where you say, listen, symptom X and Y are probably related and will get better, but symptoms A, B, and C probably won't. And I think that's like a very common conversation that we all have in clinic. But then it's like, what do we do when A, B, and C didn't get better, or that idiopathic syrinx that we see in clinic that has back pain that we can't fix surgically? It's just, I almost wonder if really you guys could expand your services considerably to the spectrum of non-organic symptoms, or symptoms that may have a minimal organic component but a maximal, almost like a psychological amplification. I don't know if that's like a real thing or not, but it feels that way sometimes. Yeah, my partners, you guys have thoughts on this? I mean, this is something we see all the time in clinic.
Yeah, I agree with you, Jay. I think there's a lot of patients with Chiari where they're like not classic Chiari headaches that you say, well, if it gets a little bit better, that's a bonus, but we're really doing the surgery because you have a syrinx and you have sleep apnea or whatever.
And so and what ends up happening, like Jenny's describing, is that we have these kids who are left post-op with like the psychological conviction that there's a link, an organic link between their symptoms and and the MRI or whatever. And so it's just like we would love your help with these kids. I mean, this is like a swath of neurosurgery patients, probably neurology patients too, that they float out there. They don't do great. Like they use a lot of clinic utilization, neurology, neurosurgery, psychology, psychiatry, but then we never really like, I don't feel like they have a lot of direction, but they're not so bad that like Bianca, you're admitting them to rehab. Like they're not that bad, but they're not
Yeah.
great. And I think there's more kids in that category than we probably can count. Anyway, it's something to consider. It
Yeah.
vexes me. I mean, I feel like that's one of the biggest things that I see all the time in clinic, that like I feel like we don't help. We just kind of say not neurosurgery and then we discharge them.
Yeah. That's something we can think about
Mm.
for sure. Thanks for bringing that up.
Mm.
Hi, Bianca. It's Katie. I agree with everything that Jay just said. We have that population, but I have a question about it's not specific to this mutual patient, but it comes up because he's currently under both of our care. When we have a patient that it's kind of hedgy, like, okay, they have bigger ventricles, but their symptoms do not correlate with the degree or severity of their symptomatology. But so we're still working them up medically, but they have a diagnosis of, functional neurologic disorder. How do you want us to, like, in the medical side of things, not make the focus what we don't think is the problem, but we're still working it up? Like, how do you feel is the best approach to talk to the patient more so than the family? Because the family, I don't feel like we have to worry about as much, but I think everything that you presented today makes me concerned about, like, how do you want us on the medical side of things, when we're still working things up, to support the fact that we do believe that this patient has a functional neurologic disorder, but we're still exploring whether this other finding on MRI, like Jay was alluding to, is contributing.
Yeah, I mean, people can definitely have, like, you can have epilepsy and you can have non-epileptic seizures. You can have medical conditions and FND. So it can get very tricky and complicated, but I think just letting them kind of know that, like, we have multiple things going on. You definitely have FND because we saw this on exam, and we believe that is FND, but we're doing these tests because I'm seeing these other things, or I have these other concerns. So there may be something going on separately from the FND. And just knowing that there's going to be two different treatment paths, whatever you recommend for their medical condition, And then also all of the treatment for FND. But it can get confusing and complicated.
Yeah, I think I agree, like acknowledging that both can exist. And sometimes I mean, once I have all the information from the medical teams, but I do talk about, X, Y, and Z medical thing is causing a lot of stress on your body and it's activating that autonomic nervous system, contributing to these FND symptoms. So while your team is working up this thing, this other, finding, we will work on these, functional goals. And I think I think you're speaking to that inconsistency of like, these symptoms are inconsistent with a known neurological or medical condition, right? And but it is challenging. These are hard questions.
Yeah, they definitely are the most challenging patients. I think you guys are awesome and you did an amazing job with the presentation. And I don't know if I could do what you do. So thank you.
Oh, thank you. And we're learning every day and still
Yeah.
working on getting better.
Yeah.
Well, thank you so much, everybody, for inviting us and letting us share this with you.
Yeah, thank you.
Excellent job. Thank you both. And
Thank
thanks
you.
for all the engagement. I loved it. It was wonderful.
Maritza, you had a question. What's the average length of stay? I don't know if she's still on. Oh yeah. It's about 2 to 3 weeks, but sometimes it could be longer, like 4 weeks. But I don't have the average like actually calculated, but I want to say it's about 2 to 3 weeks.
Thank you.